So I'd like to welcome Dr. Mark Houston tonight
Hey,
because,
Deanna.
hello. I know, Dr. Houston, that you're not often on Facebook, so this is a huge treat for us to have you.
It's a rarity. First time, actually.
It's the first time.
First time
Wow. Well,
ever.
welcome to the world of social media. How terrific it is to have you.
Thank you.
And your bio is quite extensive here, and I just want to read a little bit of it for everybody. You're a highly recognized cardiovascular and hypertension specialist, serving as a physician at St. Thomas West Hospital in Nashville. And you've got lots of different leadership positions at the university, and you spend a lot of your time, I would say, writing, seeing patients. You and I have written some book chapters together. What I really admire about you is that you have really set the tone and been a forerunner in this whole field of integrative cardiology. So thank you for all of your many contributions. I mean, they're just stellar. And so it's really an honor and a privilege for us to have you tonight to talk about this latest study that came out in July.
Thank you for
And
those
so
laudatory comments, Deanna.
So let's talk a little bit more about this particular study, this review study, this Cochrane review. And Cochrane reviews always get a lot of attention. Now, this one came out in July, basically telling us that omega-3 supplements are not useful for cardiovascular disease prevention. And so I would like you to talk us through this a little bit and to let us know what that review said specifically. What were they looking at? And let's talk about some of the flaws or the things to consider as we think about a large meta-analysis like that.
Okay. So let me set the stage for what's happened in the last 2 years with omega-3 fatty acids and what's been termed cardiovascular disease. And this is where we really get into trouble is definitions. So
Yes.
the Cochrane meta-analysis was about 112,000 patients. But its whole concept was cardiovascular. Now that means coronary heart disease, heart attack,
Mm-hmm.
stroke, peripheral arterial disease, heart failure. I mean, it's a whole gamish. Okay. And there was another study by JAMA did the same thing, cardiovascular. And
Mm-hmm.
only one of the three meta-analyses that's come out in the last 2 years from Mayo Clinic limited to coronary heart disease, morbidity, and mortality. So you've got to distinguish that. So what I want to do tonight is take out the pieces from Cochrane and
Excellent.
show you the flaws, not only of the studies, but also of the way it was reported. Here's the bottom line. If you
Yeah,
go
let's
to
unpack this a bit
coronary heart
because
disease morbidity
mm-hmm.
and mortality only, take out the strokes and all the other things.
Right.
There was actually in the whole trial overall a 7% decrease in cardiovascular deaths and event rates in the Cochrane analysis. They didn't report that.
Now, why wouldn't you report that
However, if
though?
you go in and take out congenital heart disease
Mm-hmm.
and heart failure from that group of, quote, cardiac events, it's actually a 16% decrease in myocardial infarction, coronary heart disease deaths, and event rates. Statistically very significant. And also in that trial, they neglected to report at all, even though it's in the results very clearly. If you took over 4.4 grams a day of omega-3 fatty acids, it was a 68% reduction
Hmm.
in myocardial events, coronary heart disease deaths and events. By lumping everything together, they've ignored the number one killer, which is coronary heart disease. They hid all the results in there and did not report them in their conclusion, which is totally false. The
Hmm.
bottom line is Cochrane actually showed a huge reduction in coronary heart disease events and mortality and death rate, which is consistent with the Mayo Clinic meta-analysis.
So let's talk about that a little bit. You just mentioned 4.4 grams. I'm curious if they looked specifically at the levels of omega-3s. Uh,
No, they did not. And that's the problem. Among other things, there was no pre or post omega-3 index or levels ever measured. There was very poor compliance analysis. They didn't correct for toxicology issues.
Hmm.
And, and in that report, there was a dose-related response. In other words, if you were at 250 milligrams or less, nothing really happened. But every incremental increase in omega-3s up to the 4.4 was a consistent decrease in cardiovascular death and event rate, even in Cochrane, which they didn't even report.
So, why was there a disparity? Why was that not reported? It seems like it's pretty straightforward based on what you're saying, and I know you really like to mine the data. So, what happened? Why was that not reported?
To be honest, what they should have done is said, if we lumped cardiovascular disease as I've reported it earlier with the definition, there wasn't much different. But let's dissect out stroke. Let's dissect out coronary heart disease. And they had been honest with their own data. I mean, it's just their data. You can't refute it. They should have said, we saw a significant decrease in coronary heart disease death and mortality, dose related, primary and secondary prevention, even with all the flaws that are inherent in a meta analysis, which we did. Now, the
Right.
other thing, remember, Deanna, this was 112,000 patients. Okay, it was a not a good meta-analysis to begin with. But let's compare this to the Mayo Clinic, 825,000 patients. I mean, it's not even close.
Hmm.
And the Mayo Clinic study, which was much better, that looked only at coronary heart disease. That's the difference. They didn't look at cardiovascular. They looked only at coronary heart disease. And what they found is the same thing, dose-related effects. And if you had a patient who had a triglyceride over 150 and an LDL over 130, enormous reductions in cardiovascular events ranging anywhere from 7 to 16%. Isn't that interesting? Almost exactly the same numbers in Cochrane had they reported it correctly.
Fascinating. Now, do you think, a number of questions come to my mind when I think about disparities in studies like this, especially when they don't coincide with findings from other studies. So I know that in this Cochrane review that it seemed that many people were very chronically ill. And I'm wondering do we think that just by having a supplement without looking at food, activity, all of the other parameters that are important for cardiovascular health, that really forms the context, right? And so, was there a difference in the different populations that they were looking at? Were they on bad diets? Were they inactive? Were they sedentary? Were there other factors to consider in addition to the omega-3 supplementation that maybe weren't effectively controlled for?
Absolutely. There were so many confounding variables, as there is in virtually all meta-analysis. So it's a different population they selected. They couldn't control for all the things you just talked about. They just couldn't because these are retrospective and some randomized control, but they're all mixed up. It's sort of like one of my friends once said, if you go to New Orleans and get some bouillabaisse, it only takes one bad fish to make it stink.
Mm-hmm.
Well, it only
He's
takes one or two bad studies that are outliers in meta-analysis to make the whole thing invalid. So you're comparing literally oranges and apples between these three meta-analyses. But if you're careful and you go in and pick out what you ask the right question, and the question is this: if I give omega-3 fatty acids to a population and I look at just coronary heart disease death and event rate over a period of 5 years or so, can I show a reduction in those events, reduction in death? Can I show a dose-related response? And can I show that it works in high-risk patients, as a secondary prevention, but also works perhaps in low-risk patients as primary prevention? The answer, if you look at all three trials and take out the best data, is the answer is yes to all of those. Omega-3
mm-hmm.
fatty acids work. And what's really frightening to me is we have what are apparently good investigators who seem to have an agenda to destroy omega-3 fatty acids for some reason, which I don't understand yet. I have an opinion, but I won't say it live on Facebook. But the problem is they have misled results. Their conclusions do not match the results, and they're absolutely wrong.
So this is pretty compelling to think that something with such visibility is out there, and many people are now thinking that they should stop taking their omega-3 supplements because of this. This study definitely got a lot of media attention. So, what can we proactively do? What are some of the features that we need to be looking at when it comes to omega-3 supplementation? Let's talk about quality. Let's talk about dose. I want you to talk about perhaps some other biomarkers, perhaps SNPs. How does the larger picture of our health tie into omega-3 supplements? For example, I take omega-3s on a daily basis. I like the higher concentrate so I can get a higher dose. So, talk about quality. What should we be looking for in the omega-3 supplement that we are choosing?
So you've got to be careful to buy only from nutraceutical companies that have quality control. And, there's only a handful of those in the US. In fact, in all these meta-analysis, they didn't even measure mercury levels. All right. So you've got to get a high quality. Number two, you have to measure your baseline omega-3 index and see, where you're starting. If it's already 8, you're not going to see a huge difference if it's already normal. But if it's low, the impact is going to be huge. None of them measured pre and post treatment. And they didn't
Let's
have any
talk
quality.
about that right there, Dr. Houston. I think that that's a really relevant point because I'm sure that some people are thinking, well, how do I get my levels tested? And what is normal? What are we looking at? I know Dr. Bill Harris talks a lot about this. And so maybe just give us a quick thumbnail on number one, how do we get our levels tested? And number two, what's considered normal? What should we be looking for?
Okay, so there's a lot of labs, Deanna, that measure omega-3 index, and it's usually a red cell index. There are other ways to measure, but that's probably the best. 8 is considered a good normal level. Now you can go higher; it's not going to hurt you, but
I'm
anything below,
12. I'm at 12, by the
yeah,
way.
well, if you're below 8, there's a declining benefit. So you want to get it to at least 8.
Excellent. And how often should we be testing those levels?
So you get a baseline, and then check it about 4 months into treatment. And then probably after another 4 months, and you keep checking it until you get to 8. After you get to 8, you can do it once or twice a year just to verify that you're at 8 or better.
That's excellent. And should we be looking at other fatty acids as well when we get that omega-3 index? I mean,
Yeah,
what about the
absolutely.
omega-3 to omega-6 ratio? What about looking at arachidonic acid? Should we be looking at the series 1 prostaglandins? What else should we be in
Yeah,
tune with when we go to get our fatty acids
you really
tested?
want to look at all the things you just mentioned, all the fatty acids, because if your omega-6 is high, even though your omega-3 is high, you can have some negation of that effect. If your saturated fats are elevated, if your trans fats are elevated, all those are going to have a negative effect, even though your omega-3 index is good. In fact, in the studies I just mentioned, particularly like Cochrane, for example, if you took the patients who were on, let's say, saturated fats, refined carbohydrates, monounsaturated fats, and you switched them to
Mhm.
omega-3s, every single group had a huge reduction in predicted and actual coronary heart disease event rate and death rate. They didn't talk about that either. So
Right.
in the real world, you have a bad diet, you give them something better, it's going to have an impact.
I'm so glad that you mentioned that because you and I were authors on a review article that came out earlier this year in the American Journal of Clinical Nutrition. And we dove deep into the science on cardiovascular health and different elements in nutrition. And you just mentioned one of the buzzwords that we did speak about in the article and that we hear out there today, which is saturated fat. In fact, there was just another media release talking about saturated fat, coconut oil. Why don't we just tell the listeners kind of general views about that vis-a-vis omega-3 fats? Should we be watching our levels of saturated fat? Should we be, I think that coconut oil has become so popular and so prevalent in marketplaces and in restaurants now because it kind of has this health halo. What's your take on coconut as it relates to omega-3s?
Yeah. So once again, there's a lot of myths out there about saturated fat. So let's give you the truth, what it really is based on clinical trials. Number one, saturated fats, some are not bad and some are bad.
Yeah.
And what we found, what you and I found in our clinical review, is that a saturated fat that has a carbon length of 12 or greater in general, that's a long chain fatty acid, is more likely associated with coronary heart disease than the short chain fatty acids, which are C10 or less. So that's what you want to do. And in the context of coconut oil, and people don't recognize this, coconut oil is about 93% long chain saturated fats, C12 and higher. So you don't want to do a lot of coconut oil. It's probably not in your best interest. Now, if you took all the saturated fats, all of them together, and you substituted omega-3s in the clinical studies, everybody gets better by
Yeah.
switching to omega-3s. The problem is none of those trials separated out the C12 or higher and the C10 or lower to see if there's a difference in the two groups when you give isocaloric substitution with omega-3 fatty acids. And that's key too. It's got to be isocaloric, because if you don't do isocaloric, it's like, well, let's give half of this versus twice of that. You can't call it even.
You can call it even. And isn't so much of the effect not the fat itself, but what it's being replaced with? You know,
Absolutely. So whatever your company is can have a big difference on what happens with coronary heart disease. So as you point out, let's take the worst fat there is, trans fats.
yeah,
So if you have a high trans fat diet and
yeah.
you're consuming 6 grams of omega-3 fatty acids per day, the trans fats are going to cancel out the beneficial effects of even the high doses of
Yeah.
omega-3s. So if you get
Mhm.
those out of your diet, you do better.
Yeah, and now we know about trans fats because that has to be listed on the food label. And if we're not eating a lot of processed foods, then we don't have to think so much about that.
And they're
So,
sneaky with that one too. They still get it in there, but it's below a certain level. So it's a
yeah, it's below zero
zero on the
point
label.
0.5 grams. Yeah, it's true. So, tell us, I'm kind of curious how you supplement for yourself. I know you walk the talk. You're one of those medical doctors within functional medicine, integrative medicine that you know your stuff and you put it into action. So I'm curious, do you look at your omega-3 levels and then supplement
Yeah, I'm
accordingly,
sort
or?
of integrative cardiovascular guinea pig, and I have always taken supplements and checked to see what they actually do, so I can figure out, is that good for me? Is it bad for me? What dose do I need? So I've been doing this now for over 15 years with different supplements. So I've got it down to a fine art now, but I take about 5 grams of mixed omega-3s, DHA, EPA, with a little GLA and some tocopherols mixed together. And I have checked my omega-3 index. Mine's about like yours. It's between 10 and 12 most of the time.
I think we should have a contest.
Probably, man. How many pills should you take in a day?
Well, you mentioned the complexity of omega-3s, and I think that most people, when they think of omega-3 supplementation, they don't realize that you've got EPA, eicosapentaenoic acid, which is 20 carbons, five double bonds, and then you've got DHA, which is 22 carbons and 6 double bonds. So you just mentioned DHA, and you even mentioned GLA. So can you talk a little bit about EPA and DHA? Do you think that the Cochrane review got into looking at those individual omega-3s and looking at specific conditions for which each of those is truly warranted?
No, they didn't. Now, the JAMA trial actually did. They actually listed the DHA and EPA and the doses, so you can go in there and dissect that out. But what you found in the JAMA trial is DHA was a little better for raising the index quicker, but once you got there, it didn't make a lot of difference. And only those studies that took over 1,800 milligrams a day showed benefit. If you were below that, didn't seem to do much. That was the JAMA trial. Now, in the Cochrane, you can't really sort out DHA, EPA breakdown, what the ratio is. But here's what we know. We
Mhm.
think that you want a fairly good ratio of DHA and EPA. This varies. I mean, you can get in arguments about this, so I'm not hardcore about this. But typically, we've gone a kind of a 3-to-2 EPA to DHA. It could be a 1-to-1. I'm not going to get upset if somebody wants to do that. It's fine. DHA and EPA are different, though. They do different things. So you want it as balanced as you can. But the other thing is, you take high doses of those two long term, you deplete your GLA.
Right.
Okay. And if you take high doses of GLA long term, you deplete DHA and EPA.
Now, just
Now,
for clarification, so everybody knows, GLA is actually an omega-6 fatty
it is,
acid.
but it's a good one.
It is a good one, but most people think that omega-6 is bad. It's
Right.
inflammatory.
Yeah.
And I think that with all of us taking really high doses of omega-3s over time and not checking our levels, we could be shortchanging ourselves of the beneficial omega-6.
Right. So you want those three. And the other thing you want is a little gamma delta tocopherol because that balances out the oxidative stress in the capsule itself, but also when it goes into your cell membrane, it stops the oxidation process. The gamma delta is one of the best antioxidants in the cell membrane. And it's the best one because we don't use a lot of alpha tocopherol. Humans are usually mostly gamma delta. So you can get those formulas in those ratios, and that's what you need to do.
You know, you're raising a really good point about making sure that your fish oil or your omega-3 supplement is protected in some way because it can go bad with heat, light, and oxygen.
If you buy supplements that have no quality control, a lot of them are coming out of China, Indochina, who knows where, and
Yeah.
they've got mercury because mercury is in whatever they're pulling it out of in the ocean, and they don't check for it. And there's study after study that shows if your mercury level is high, it cancels out virtually all
It
the
cancels
benefits
it
of
out. Yeah,
omega-3s.
I've seen those studies as well. What about people who are vegan and do they need to be concerned about getting sufficient amounts of omega-3 fats?
Well, you can get the algae-based omega-3s if that's a concern.
But
Uh,
isn't that primarily DHA and not the EPA?
yeah, but you depending on what type of vegan you are and you're not so hung up on the animal issue, there's other ways to get marine omega-3s that are healthy.
Hmm.
But again, you've got to check the mercury level because all the seafood and the sea plants can have toxins in them.
Hmm. Yeah, that's worthwhile to note.
Stay away from big fish, tuna, swordfish.
Hmm.
You don't want to do those. Go with the smaller cold water fish if you're going to do your omega-3s in a food supplement.
Exactly. I always say food first. You know, try to get it from food, test your levels, bring in a supplement. I like to bring in a supplement because I don't think I get enough in my
You
diet.
can't. It's almost impossible. Plus, you want to have the food obviously because you get the protein plus other
Right.
goodies. And there's actually shown that that's a benefit in addition to the omega-3s. But almost everybody really needs a good omega-3 supplement to get levels up to what we talked about with an index over 8.
It's true. And all of the other antioxidants too, like astaxanthin,
Yep.
a lot of the different carotenoids that
Oh,
help to
let's make
protect
one other comment too. Krill oil.
krill.
Can I
What are your
put the
thoughts
death
on
knell?
krill?
Can I put the death knell on krill oil tonight?
Okay, go
Let
for
me
it.
tell you
What
why.
do you want to say about it?
First of all, krill is what our whales eat, and we're depleting the ocean of krill, and we've got some whales that are dying from that. So it's an environmental issue, number one. But number two, if you go and look at the clinical studies with krill oil, you can't find them. There's very limited, almost no data on long-term cardiovascular events, coronary heart disease, and even the studies on lipids are pretty suspect. So what I would like people to say is don't do the krill. Do what works, which is omega-3s in the right doses, and then be environmentally conscious about the krill, which is a big concern.
That's a good point. What about a sustainable source of omega-3s from calamari? So I know that that's on their radar specifically.
Hmm.
What about cod liver oil? You know, that's such a popular oil. I remember my mom making me take cod liver oil when I was growing up. I had to have a spoonful every morning. So I know that if I look now at cod liver oil, it's not too bad. I mean, you're getting some vitamin D, you're getting some vitamin A, both which are lipid soluble. So it's a perfect matrix for those vitamins. What's your take on cod liver oil?
Cod liver oil is okay, but you can't take very much of it because if you take enough omega-3s in it, you're going to be toxic on the other A and D. So a little bit's fine, but just if you want to do that and add some omega-3s on top, that's fine to do.
Excellent.
Yeah.
Well, in our closing minutes here, I'm just kind of curious. Let's talk about butter. I just recently,
Butter?
yeah, I wrote a blog on butter, and it just seemed like there are so many great benefits to butyrate. And butyrate is one of the short chain fatty acids. If
Yep.
we think of acetate, propionate, butyrate, and if people aren't eating enough, they can also supplement with butyrate. And that's often part of a ketogenic type of program. So I'm kind of curious, what are your thoughts on butyrate and some of these short chain fats? We talked about the long chain
Mm,
and the medium that we
yeah.
probably don't like as much, but
Well,
what about the short chain?
the short chains have numerous benefits, not just on cardiovascular, but also in your microbiome and other things. So if you do C10 or less, you're getting all those short chain fatty acids, which are very healthy. And you also can do medium chain triglycerides too, because those don't have any adverse effects. So keep the numbers below C10 and less for omegas
I
and
think that's great.
and the others. Yeah.
And I know that I said that was my last question, but what's your take on the ketogenic diet? Since we are talking about fat, I'm kind of curious about just what is your take on these high fat diets? Is there a good way that you think we need to do them? Are there any
It depends
tips?
on your specialty, Deanna. If you're a brain guy, you'll love ketogenic diet because it really makes your brain work better.
What about your heart?
But for your heart, not long term. Now, the kind of saturated fats and stuff that you're getting in a ketogenic diet, or in my opinion, for cardiovascular, short term, not long term, because all the lipids get worse, and you're throwing those long chain fatty acids in there. Those are bad for you. So short term, maybe for weight loss, but no. The diet that I'm recommending now is a fasting mimicking diet, FMD. It's got the best data. And I don't know if you're coming to Nashville in September for our advanced cardiovascular course, but we'll be talking about all the diets you just mentioned, plus some others, and the fasting mimicking.
Wonderful. That's such a hot topic now. We have one question to close here. Ashley is
Oh,
asking, can you delve into that Mayo Clinic meta-analysis on EPA and DHA that you mentioned earlier? Can you talk a little bit more about how that study may have differed in terms of how it was set up, the nature of the study? You mentioned the number of subjects, but how did it compare to the Cochrane review that we were just discussing when we opened?
okay. So I didn't see the actual thing come up. Was it Cochrane she wanted me to go through, or one of
The
the
Mayo Clinic one, the
Mayo
Mayo
Clinic? Okay.
Clinic.
So
Yeah, remember how
good
you talked
question.
about
So
how it was
Mayo
collected?
Clinic was 825,000 patients, and it looked only at coronary heart disease, events, and death. Okay, did not look at cardiovascular. That's the big difference. Two very different meta-analyses. Cochrane was cardiovascular, but it was only 112,000 patients. Literally 8 times as many patients in the Mayo Clinic trial. Blows away any other meta-analysis ever published. And it pulled out the real key data, which was coronary heart disease. And in Mayo, 7 to 16% reduction in events and death for CHD. And if
Wow.
you pull out the data from Cochrane and you validate it, it's the same numbers, but they didn't report it. That's really the major issue between those two trials.
Fascinating. Well, I think you answered the question for us of what are we to do when studies like this come out? And basically, we continue to get our levels tested by going to a functional medicine based practitioner or somebody who does integrative care. I think a number of different labs are now measuring fatty acids. And so it's quite easy to get the omega-3 percentage.
I
We
have
test
a
that every
real,
4 months.
yeah, I have a really major point I want to make to the
Oh, please.
listeners in the audience. If you want to be a good practitioner, you have got to learn how to read clinical trials correctly. You cannot believe the media at all. In fact, you can't even believe the journals when they're reported because they mislead you. You've got to dig in, read the methods section. If it's a clinical
Yeah.
trial, it's a meta-analysis. You have to go in literally and pull everything out. I've spent almost 20 hours reviewing these three trials. Cochrane is about this thick. It's
Mhm.
enormous. I think I sent it to you actually.
You did. You actually wrote a response to the Cochrane
Yeah.
review.
So we've got a white
It was
paper
excellent,
that we're going to
excellent. And you called
publish
out a lot of these points that
that
you
really
talked about.
breaks down all three trials. But I want to put a plug in for you. If you really want to learn how to do clinical trial critical analysis, come to the advanced cardiovascular module in Nashville. It's at the end of September. 3 days, and we're going to take everything in cardiovascular medicine, and we're going to show you, for example, we're doing one on omega-3s, we're doing on CoQ10, we're doing some on saturated fats and
Yeah.
diets, how to read a clinical trial,
Yeah.
how to interpret the data, but then take that information and apply it clinically. So it's a very clinical program. So if you want to come to that, It's through MMI or A4M, and you can sign up and come. I think you'll learn stuff that will help you with your future for practicing any kind of medicine, whether it's cardiovascular or otherwise.
I think that's an excellent point. And one of the things, too, is MAPS, which is an online educational forum of so many different talks to help practitioners to really weed through a lot of the science that's out there to make it clinically relevant. Because there, like you just said, I mean, goodness, there are so many different studies coming our way. Who funds those studies? What was the impetus of the study? What was the methodology?
Yeah.
I think being a health practitioner these days requires great skill and constant attention to the different studies that are coming out. So
And
I
you can
really
imagine,
admire.
right after Cochrane came out, my computer was blowing up with emails because everybody is going, Houston, we have a problem.
We have a problem. Yes, I can
And do you
imagine them
believe the
saying
Cochrane?
that.
And I said, well, I've got to get it and read it because I really don't believe that the results and conclusions are correct, but I got to prove it. So that's when I got the study and went through it and said, this is really falsehood. I'm so ashamed that they reported this.
Well, and I was a bit surprised that many of the other studies had been overlooked, many of the
Mhm.
beneficial results that we had seen for years and years and years. I mean, I feel like the research on omega-3s is solid.
It is.
And so sometimes with a meta-analysis, the methodology is a bit skewed where you can only take certain trials because you're comparing apples to apples. And in so doing, you leave out a number of studies that might be really relevant and have a different conclusion.
Yeah. When you're biased against the study, you don't include it because you can make up whatever you want to decide what studies you want in a meta-analysis, which is what JAMA did. They only had 10 trials compared to like 80
Yeah,
in the other meta-analysis. So obviously there's some cherry picking going on.
there's some cherry pick. Yeah, that's a good way to say it. Dr. Houston, this has been a delight. Always a pleasure to talk with you.
You too,
You're
Deanna. Thank
what
you.
I admire so much about you is the fact that you are not just a brilliant clinician, but a very curious. You have that scientific mind that always keeps you. That's why everybody's going to you and asking, what's the latest on this? Because you have
Thank
that
you very
critical
much for
mind.
saying that. It's been a pleasure as always, Deanna.
Wonderful, and glad to have you on Facebook finally.
Yeah, this may be my first and last time.
Aw. I hope you'll come back with us.
I will. Thank you. It's been a
Thank you.
pleasure.
Take
All
care.
right. Have a
Thanks,
good
everybody,
evening.
for tuning
Thanks
in.
for joining us, everybody.
Bye bye.
All right. Bye.